was a successful campaign, and I was just remembering this morning being interviewed by reporters, not the lady here, but by other reporters who said to me at the time, "Oh, but it's a done deal, isn't it? You can't change anything, there's no point campaigning, it's been decided." And we said, no, it hasn't been decided, and we can change things, particularly if we can build a public understanding of what's going on and mobilise people to fight to change things. And we proved that that was right, and we proved that if people engage, we can do something. Now, when we set up the campaign as a whole, it was just a generalised campaign that we felt the NHS needed defending. That over the last few years, the National Health Service has been underfunded drastically. And I know John knows a lot more about that. But we felt we needed to do something that if we could save the Glenfield Children's Heart Centre, we could also save our services in general. But this meeting has been called for a specific reason, which is going to be explained during the course of the meeting. The main issue is that the Hospital Trust is proposing the removal of intensive care beds from the Leicester General Hospital. But that fits in, I'm trying to remember the exact phrase that John Adler used at the meeting yesterday. It's consistent with, that's the phrase he used, with their overall plan to reduce the number of acute hospitals in Leicester, Leicestershire and Rutland from 3 to 2. In other words, to close the General as an acute hospital, to keep some services on that side, but it would no longer be an acute hospital. And that is a plan which has not yet been consulted on, which we haven't seen the full details of, and is yet to be properly discussed. But we were concerned that the proposal to remove intensive care and some of the associated services from the General now would preempt that discussion. Almost that it would then be a fait accompli, because we can't keep up the services at the General because we have no intensive care beds. And we thought that was wrong, especially because they plan to go ahead without a public consultation over this move. That's specifically what we called the meeting for. Our position is, if you as the Trust and the critical commissioning groups can prove to us that it's actually an improvement in service and not a cut in service, then so be it, prove it to us. But let's see the arguments, let's have them out and let the public see what those arguments are about. And that's why we've called this meeting today. We have two speakers. We have Dr. Sally Ruane, who is a well-known campaigner and academic dealing with issues around the health service. And we also have John Ashworth, who's the MP for Leicester South, and who is also the Shadow Health Secretary for the Labour Party. So John has very short notice agreed to come to our meeting. Unfortunately, he's got another event that he's got to go straight away to as soon as he's spoken, so he's not being rude when he has to leave. It was a pre-organised event before we invited him to this meeting, so it's very good that he's come on to introduce the meeting. So I'll hand over straight away to John Ashworth.
Okay. Thank you very much, Chair. And can I start by paying tribute to you and all the campaigners gathered here in the room for the campaigning we did on children's heart surgery at Glenfield. And you are absolutely right. When experts and people from across the country are saying, look, there's no hope, there's nothing you can do about it, you know, we said no, we campaigned against it, and the reason we won that campaign wasn't because we played to the gallery or we marshalled people's concerns about making the arguments properly. We won that campaign because we used the evidence as to why the proposed closure of the Children's Heart Unit at Glenfield was clinically not sound. And that is so important. And that's what I want to talk about today in this contribution. But first of all, can I say, when we're here, when we gather here, can I just say tribute to all of you also, not just your campaigning on Glenfield, but your campaigning to save the NHS more generally. Because it is the 70th anniversary of the National Health Service this year, created by Aaron Bevan. And on the 10th anniversary of the NHS, Bevan did a very significant speech, and he talked about the silent ledger, which isn't included in the statistics of how much is being spent or the number of operations that are being carried out. He talked about the silent ledger of the joy when a child is brought into the world safely, or the comfort when you know you're being cured of illness, or even the knowledge that you'll have some degree of dignity in your final moments. That is what is provided by the National Health Service. And he also asked us to be the custodians and the guardians of the National Health Service. And that's what we are today, being the guardians and the custodians of the National Health Service. And why do we need to be the custodians on this debate? It's because, as you said, Chair, the proposal to move the intensive care beds from the General to the Royal may well subsequently be shown to have been clinically the correct thing to do. It may well be, when we begin to interrogate and examine the evidence, that we can see a medical argument for it. But until we see that medical argument and that clinical evidence, then people will fear that it's a Trojan horse for the closure of the Leicester General Hospital. And my concern is when you've had 8 years of austerity in the National Health Service, 8 years of the biggest financial squeeze in the history of the NHS, 8 years of deliberately not giving the NHS the money it needs, 8 years when, because of that underfunding, the hospital estates across England now have a backlog of £5 billion worth of repairs. 8 years when you've seen things get so down in the NHS that nationally we are short of 107,000 staff, including 40,000 nurses and midwives. We're short of 40,000 nurses and midwives. We're short of 10,000 doctors. On the staffing front, it's now so dire that last year, on 50% of occasions, maternity units across the country literally had to shut their doors to women in the throes of labour and were told to go up the road to somewhere else. I mean, we're so short of pathologists doing cancer tests and so on that people are waiting longer and longer and longer for cancer treatment, and we know that waiting longer for cancer treatment can have devastating consequences. So this decision to move beds and this decision to look at closing the General has to be seen in the context of 8 years of austerity in our National Health Service. Now, it may well be that when we look at the clinical arguments, that they say you have to move intensive care beds to the Royal Infirmary because that will lead to better outcomes for those people in intensive care. But part of the reason why it may well lead to better outcomes for those people in intensive care is because for 8 years you've not got the staff in the NHS. I mean, I suspect what the John Atlow knows will say is because, you know, we need all the staff at the Royal. Well, that is not, I mean, that is because of 8 years in which the Tories have been cutting the NHS, so we don't have the staff in the National Health Service. It may well be that is their argument. I suspect it is probably what their argument is, because it's not unusual in parts of the country for services to be reconfigured and put in one central place because there isn't the staff to be spread out in an area. I suspect that will be the argument when if they provide us with the argument. But my argument in back of them is this, right? If I was the Health Secretary, we might have a general election soon, who knows, it's all shambles in Parliament, but you know. Austerity would end. We would start giving the NHS the money it needs. And we would end these SDPs, which were about closing services. Don't forget, the original proposal on the SDPs there in Leicester and Leicestershire and Rutland was to cut hundreds of beds. I mean, they wrote back on that because of the campaigns that we did. But now we know that the proposal is probably to move all the services, all the acute services from the General Body, though we've already shifted maternity, you know, of course. I mean, my youngest daughter was born in the General, well, that's all gone over to the Royal Infirmary. And to close the acute services and put it all at the Royal. And then they say, well, if we do this, we'll probably get more access to some capital investment, which will allow us to build more at the Royal and build more. They're even suggesting building a complete new hospital, a women's hospital at the Rock. Having a new women's hospital for the city, I'm not necessarily opposed to that, but what sense does it make to be building more services on top of the services already at the Rock, and then closing a very good facility at the General? We've got to think about is there a better use of the facilities at the General? But why do they have to do that? Why do they have to do that? And again, I want to emphasise this point, because in some ways the hospital hands are slightly tied. Some of the decisions they make are national decisions. Why do they have to do that? It's because they've been told by the Tory government that they will only get access to capital money, i.e. the money that allows them to build, the money that allows them to renew their equipment, the money that allows them to deal with the crumbling ceilings and walls. They will only get access to that capital money if they sell off their existing assets. It's called the Naylor Report. Some of you may have heard of it. And I did a bit of research recently, I got it in The Guardian, which showed that across the NHS estates now, 1,700 hectares of land has been put up for sale. Fire sale of NHS assets. And they're trying to sell it off without any public consultation, without any wider discussion with the City Council or the residents or the health campaigners or patients or staff. And they're being forced into this because the Tories say to them, you will only get any money for capital investment if you sell off land. So it's a Hobson's choice that the hospitals are faced with. If they want to put more investment into the infrastructure of the Royal, they have to sell off land at the General. That's not a real choice. Again, if we are fortunate enough to get a Jeremy Corbyn Labour government in the coming weeks and months, we would again end that and would put £10 million worth of investment into the capital and infrastructure of our NHS. But things have to happen in politics for that to happen. We hope that it does, but we'll see. But in the meantime, I would say this, right? I've written to the Chief Executive of the hospital. I've spoken to Ellie Kelvin, who's the councillor of Leicester City Council, who's in charge of the scrutiny issues on this matter. I have said very clearly there has to be public consultation on this issue. And none of us in this room are reactionaries or stuck in the mud. I think we know that there is overwhelming clinical evidence. We accept things to change. The NHS has not been preserved in aspect for 70 years. We know things change. We know advances in medical technology and different ways of doing things means things change. None of us are Luddite in our approach. We just want to see the evidence in our approach. We just want to see the evidence. We just want to interrogate the evidence. We just want to be convinced that it is the right thing and that it isn't a Trojan horse for the closure of Leicester General. So I would say to the hospital, who say that they've gone through the various appropriate procedures in 2015, I would say you have nothing to fear from public consultation. Because if you're absolutely convinced you're making this decision for the right medical reasons, then let's have that discussion and that debate, and let's engage the public. Because I think people are going to be shocked. They're going to be shocked when people realise the implications of this. They're going to be shocked when they realise that once these beds are moved, we know what will probably happen. Sally will go into this in more detail. We know that once these beds are moved, then other surgeries and procedures will start going, hang on a minute, it's too risky for us to carry out that procedure, because we haven't got the intensive care beds if something goes wrong. So then they start shifting. And once your different disciplines are shifted, once there's less anaesthetists at the General because they're all at the Royal, once there's less qualified surgeons at the General because they're all at the Royal, then other departments start shifting as well. And before you know it, it's kind of, well, what can we do? If you want safe quality healthcare at the General, we can't do it with all the other relevant associated allied health professionals who we need to deliver that safe healthcare at the General. So that is the big fear. And then, of course, what can we do then? We'll close the General and the acute hospital, we'll keep 1 or 2 services there, but we'll sell off the land and housing, and then we'll have 1 or 2 community health facilities there, so there'll still be something ticking on. That is the fear. That is our fear. And unless we have a proper public consultation, where we can look at the evidence, and we can have the argument, we can have the discussion, that fear will be well founded, I believe. So look, I have been calling for public consultation, as has
your Labour councillors. I mean, this isn't a party political event, but I'm told the Conservative councillors from the county voted against the public consultation yesterday. I don't understand why, but apparently they did. The Labour councillors from Leicester City voted for a public consultation. I've already had these discussions with the Chief Executive Hospital. I've written to him, I've spoken to him on the phone, and I think we've got to keep the pressure up for a proper public consultation. And I know, my final point is, I know many of you will want to in this room, out of frustration, criticise the hospital a lot. I just re-emphasise, they're in this situation because of 8 years of cuts. 8 years of not being able to recruit the staff that they need, 8 years of running the NHS on a shoestring, and now because they've been told they can only do changes and upgrades and reconfigurations and rebuildings, they'll only get access to that money if they sell off their assets. So, yes, I'm sure you want to share your frustration with the hospital, but don't forget the context of why this is happening. It's because of the Tory cuts and austerity. And ultimately, that's what we're going to bring to an end. Thanks a lot.
Thanks, Steve. I want to say a bit more about what the proposals are, why the hospital wants to introduce them, what are two of the kind of clinical problems that there are with them, but then I want to focus on the case of consultation. So the proposals, first of all, as John has said, the plan is to move all of the intensive care beds, so those are beds for 6 patients that are in the 3 beds, to move all of those beds out of the general and to move them either to the Belvoir or to the Royal in split them up. We might even get an extra 2 or 3 beds, intensive care beds as a result of that. It would be one behind at the general, and the purpose of that bed would be to stabilise somebody who needs intensive care at the general and then get them out and get them out to the Belvoir or the Royal. And they will also be for what we call high dependency beds, or units at the general as well. But otherwise, the rest of the intensive care closes down at the general. And as John hinted there, as soon as you move your intensive care beds out of your setting, you immediately start identifying the other work that you can no longer do on that site. So straight away, kidney transplant or renal transplant will have to move away from the general and it will be going to the Belvoir. Then there are a set of services around the liver and the gallbladder and the pancreas, and all the inpatient care, so when patients have to stay in hospital, that will all move away from the general onto the Belvoir site. Any urology patients, so urology is the urinary tract and then reproductive organs, any urology patients who are considered to be high risk, they need to move over to the Belvoir site so that they can be on site where there is intensive care. General surgery is going to have to move out of the general and it is going to go to the Royal. And colorectal surgery or surgery on the colon is going to have to move out of the general and go to the Royal. So you can see already, can't you, that we're not talking just about a number of intensive care beds, we are also talking about other services which have to have intensive care on site. Because intensive care services are all services. It's a core service that a hospital has to have before it can do other things. So you've got a range of services moving out. Now, they are going to be leaving behind some of the kidney care, so nephrology is medical care, surgery. Outpatient, liver, pancreas, etc., that will be staying behind at the general. Day care for those patients will be staying behind at the general. And the non-critical urology patients will be there. And that really takes us into one of the problems with the proposals, which is that some services are going to be split across 2 sites. Yeah. So, and the hospital is the first to acknowledge that this isn't desirable, and ultimately it isn't sustainable. And so what they are saying is that there has to be a second round of moving these services is a way of getting to hear different points of view on something. And really what's happened here is that they've looked at the clinical details and they've focused on the clinical details. And what they haven't thought about is all those other issues that John has already just raised about, oh, hang on a minute, what's the impact on the general? Is this a Trojan horse for closing down the general in the future, on which we have no consultation so far? So, and they don't seem really to have thought about the wider set of issues and the kinds of personalities that people are working on. What the impact on access will be on the services we need. I live in a city. If I want to go to the airport, I get in my car. If I want to go to the general, I get in my car. I want to go to the Russian bus. But if you live out in East Leicestershire or you live out in Rutland, it will take you half an hour to get to the general, but probably more than twice that to get to the Russian. It has a big impact on accessibility. And along with that, they also threaten the loss of their community hospital as well. And it's quite interesting that one of the strong contingents at yesterday's council meeting is the contingent of money. They're very strong about this. They can see services are being centralised because there isn't the money to come from different sides. And if you live on the periphery, that has an effect on you. You know, and it's, you know, it doesn't matter if people generally have a higher income. You know, in the city, the practice of the NHS is an NHS for everyone, whatever their level of income. And people are highly concerned with the service needs from them. So, consultation allows information to be brought into the public domain. It increases transparency. And one of the reasons that people don't know much about this is because most of the documentation in the public domain is a 235-page full business case. And if you want to go off and read that, by all means go off and read it. If you suffer from sleeplessness, I think you will. It is incredibly difficult to work your way through. And I was involved in a report that was published last month, which was trying to make some of that information more accessible to people. It was trying to bring it out into the public domain. So one of the things that consultation can do is it can bring things, it can make things more transparent. So as John said, let's get the evidence into the public domain so that we can look at the evidence. We're not evidence, we're not trying to keep the support reserves up and prevent improvements, but we do want to look at it in the round. And one of the reasons that people particularly want consultation on this issue is this wider question. We do know that the longer term plan is to close the general. John's absolutely right about that. But we'd like to close the general and we would like to consolidate services on the Belvoir and on the rural sites. Now, you're there, and what the NHS is saying is, oh, this has got nothing to do with that. They're saying it's consistent with, it's compatible with closing the general plan in the future, but it is not a step towards closing the general plan in the future. And this is where we really struggle to get our heads around that. If you want, you've just heard a list of all of the services which are now within that general. And the idea that somehow this will all be reversed in the future, that no, we will choose the general as a hospital, but we always fail, there's belief in it, doesn't it? I think it just stretches it. So they're saying, well, we want to consult with more general in the future, but we know they've been saying that to us now for about 3 or 4 years. Initially, we were going to have that consultation on the future of the general, on the future of all of our services, back in November 2015, and we're still waiting for that consultation. It's not their fault, but every time they think it can happen and something else changes, and they have to explain it and put it together. We thought it was going to take place this year, and we're early this year, it's going to be next year, and we just go from there to our consultation next year. So we're saying, well, hang on a minute, we've already made changes. We want to talk about it now. We want to talk about these issues now. We want to be able to talk about what people's concerns are, to start identifying what the issues are. In particular, my main thing is I'm not particularly a bricks and mortar person. I'm not particularly attached to a set of buildings. I can understand people who were brought up in Leicester and born. I can understand and feel that emotional attachment. I feel like my kids just with that husband. I don't feel it particularly about the generals. You know, I've only been there for 20 and maybe